The following podcast is part of a certified educational activity titled Recognizing the Burden of Patients Living with EGPA, an exploration of best practices in diagnosis and treatment in the context of a multidisciplinary approach. Access the entire activity and complete the post-test at peerview.com/TTA860. Downloadable slides and practice aids are also available.
Welcome to Recognizing the Burden of Patients Living with EGPA, an exploration of best practices in diagnosis and treatment in the context of a multidisciplinary approach. So tonight's panelists will be Dr. Praveen Akathota, myself, Dr. Penise Corey, and Dr. Philip Seo. Our goals for today are to expand your knowledge regarding the association between EGPA and comorbid or associated eosinophilic conditions and the burden on the patient quality of life. Our goal is to improve your understanding of the pathophysiology of EGPA and the rationale for targeted biologic therapy. You can enhance your ability to use evidence-based approaches to diagnose and differentiate EGPA from other eosinophilic disorders and help you select personalized treatment for your patients with EGPA based on evidence-based guidelines and recent clinical data. So we'll start with the EGPA epidemiology. EGPA is classically considered among the small vessel disorders of the ANCA-associated group. It's relatively rare, with an estimated 5,000 cases per year in the United States and approximately 14 cases per million worldwide. The mean age at onset is 40 years, but varies, and occurs equally in men and women. It also may be underestimated in prevalence. And as you can see on the left side, it is considered amongst the small vessel vasculitides. There are many others, and we'll discuss in the session how to differentiate between the other vasculitides. So the reasons for the underestimation may be due to a couple reasons. One of them is the lack of recognition because it's so rare. EGPA respiratory symptoms are often being treated with systemic corticosteroids for what is presumed to be severe asthma, and sometimes that can mask the symptoms and the development of the vasculitis. It also may be underestimated because certain medications can partially control the symptoms, such as high-dose inhaled corticosteroids. So how do we characterize EGPA? There are some key features, and I'll go through them, one of which is moderate to severe asthma. Patients often have peripheral blood eosinophilia, and that is classically described as being greater than 10% or more than 1,000 eosinophils per millimeter cubed. Patients can have mononeuropathy or polyneuropathy. They can develop pulmonary infiltrates. They often have sinus disease, including paranasal sinus abnormalities on imaging. They can also have nasal polyps. And if a biopsy is taken, you can frequently see extravascular eosinophils or frank eosinophilic vasculitis. ANCA testing is performed in patients, and it can be positive in about 30 to 40% of all patients, depending on the series that's looked at. That being said, the clinical presentation of EGPA can vary greatly. There's a lot of different features that can be manifested in different patients. And typically, the reason for our education is that many different specialists and disciplines can be involved in the diagnosis of EGPA. And so therefore, a multidisciplinary approach is necessary for recognition, accurate diagnosis of EGPA. I highlight some of the more common features. And so in the pulmonary system, we've already mentioned that asthma can be prevalent, but patients can also have infiltrates, effusions, and in rare cases, hemorrhage. In the ear, nose, and throat, the most common features are sinusitis, but as I mentioned, patients can have nasal polyposis, serous otitis, as well as neurosensory hearing loss. In the heart, pericarditis, myocarditis, as well as cardiomyopathy and heart failure can be present, and in some cases, patients can have infarction. The GI tract can also be affected with eosinophils in various different segments, such as eosinophilic gastritis, enteritis, and colitis, and in rare cases, there can be perforation. The skin can sometimes demonstrate subcutaneous nodules, Patients can also have hives, and a more classical feature is purpura. Um, Glomerulonephritis is more common in patients with ANCA-positive disease, but patients should be checked for kidney involvement. And the nervous system, the most classical feature is mononeuritis multiplex, but patients can also have peripheral neuropathy. So how do you differentiate EGPA from other eosinophilic disorders? So the most common diagnoses that can be confused with EGPA include chronic eosinophilic pneumonia and hypereosinophilic syndrome. And as you can see from this chart, there's quite a bit of overlap between these three conditions. In chronic eosinophilic pneumonia, the patchy infiltrates are typically peripheral in nature, whereas in EGPA and HES, they can be patchy or distributed throughout the lungs. None of them typically have fulminant respiratory failure in comparison to acute eosinophilic pneumonia. And for chronic eosinophilic pneumonia, there is typically an allergy and asthma history similar to HES, but this is more prominent in EGPA. The vasculitic features are really what differentiate EGPA from the different diagnoses. And as I mentioned, they can also have ANCA positivity. Cardiac features can be present both in EGPA and in HES. And so it's important to use other features to differentiate these conditions. And then the neurologic features can sometimes help differentiate EGPA from HES and CEP. So these are the diagnostic criteria that have been used for EGPA that have been developed and used for clinical trials. So in a patient with asthma and eosinophilia greater than 1,000 or more than 10% of leukocytes, having two or more of the following features is characteristic of EGPA. And so what are these? So the first is a biopsy showing histopathologic evidence of eosinophilic vasculitis or perivascular eosinophilic infiltration or eosinophil-rich granulomatous inflammation. Neuropathy, mono or polyneuropathy, including motor deficits or just nerve conduction abnormalities can be characteristic. Pulmonary infiltrates that are non-fixed, so they are in different places on different scans. Sinonasal abnormalities, cardiomyopathy established by echocardiograms or cardiac MRIs, glomerulonephritis, including hematuria, red cell casts, or proteinuria, as well as alveolar hemorrhage demonstrated by bronchoalveolar lavage, palpable purpura, and a positive test for ANCA, including either MPO or PR3. So in 2022, the ACR and EULAR created classification criteria for EGPA. And these criteria are supposed to be considered in patients where a small to medium vessel vasculitis is already diagnosed. And alternate diagnoses that might mimic a vasculitis need to be excluded prior to applying these criteria. And so the classical criteria are listed at the top, and those include obstructive airway disease, nasal polyps, or mononeuritis multiplex, and these have different scores. Listed below, there are the laboratory and biopsy criteria, and this includes blood eosinophil counts greater than 1,000, extravascular eosinophils on biopsy, as well as some negative criteria that would point you away from the diagnosis of EGPA, including PR3 antibodies and hematuria. So after summing all these scores for these 7 items, if there is 6 or more present, this is needed for classification of EGPA and differentiating it from other types of vasculitides. So there's quite a lot of systems that can be involved in EGPA. So how do you decide what to test patients for? And so this is a nice study that had a table that demonstrates the types of indications and clinical features that might necessitate a further procedure to diagnose EGPA. And so, for example, if a patient has peripheral neuropathy, one might consider EMG or ENG or sural nerve biopsy to make the diagnosis. If there are gastrointestinal symptoms or bleeding, an endoscopy might be considered. If there are ENT abnormalities, nasal endoscopy or a sinus CT scan, or sometimes procedures to take a biopsy might be needed. If there are lung infiltrates or pleural effusions, a BAL Sometimes sampling the pleural fluid or a lung biopsy might be needed to make a diagnosis. If there are clinical signs of ABPA, there's certain specific IG testing or IgG testing, as well as BAL cultures in the lung to look for Aspergillus species. If the patient presents with purpura, skin biopsy might be needed. And if there are signs of cardiac involvement, including abnormalities on an echocardiogram, a cardiac MRI, or endomyocardial biopsy may be required. If there are vascular events or high cardiovascular risk, arterial and venous Doppler ultrasound might be required. And CNS manifestations might push one to get further testing of the brain and spinal cord MRI, including CSF analysis. And of course, any other features that might point you to different testing based on the clinical presentation. So EGPA has historically been described as evolving in a phasic development pattern. However, these stages may overlap quite considerably or not be present in every patient at all. But just for interest, the first stage is a prodromal period where patients will develop allergic disease, usually allergic rhinitis that progresses into asthma, and this may precede the disease by several years. The second stage has always been described as an eosinophilic phase, where patients will then develop peripheral blood eosinophilia, as well as eosinophil infiltration into the various tissues that are involved. And then the last stage is typically described as a vasculitic stage, where patients will develop this necrotizing vasculitis, granuloma formation, and this is where the more serious manifestations can develop. As I mentioned, this typically can develop over years, but it can be more acute and develop over months in some patients. So overall, EGPA, as it involves so many systems, can result in quite a large burden of disease. And despite the rarity of EGPA, the range of organ systems involved and its relapsing remitting nature puts a large burden on patients and the healthcare system, including requirement for substantial levels of oral corticosteroid use, severe asthma exacerbations, including hospitalizations, as well as a large burden of healthcare resource utilization and costs due to the large amount of testing. And the under-recognition of EGPA can further add to this burden. So a patient survey was performed to further understand this burden of disease, and the interim results of a longitudinal qualitative substudy of patients, with 9 patients answering with both relapsing and refractory EGPA from the phase 3 Mandera study. These patients were interviewed, and they showed that more than 35 different symptoms were reported as being bothersome for patients. All of the patients experienced difficulty breathing, as well as shortness of breath. 78% reported coughing, wheezing, and neuropathy. 67% had fatigue and nasal congestion or discharge. 89% reported impaired ability to work and exercise, and 67% had an impact to their sleep. 55% experienced disruption in their ability to engage in social activities, and 44% experienced difficulty in everyday activities. So this suggests quite a large burden on patients. So when we asked what effect EGPA symptoms had on the quality of life, 40% said that this was extremely affecting their quality of life. And another 40% said it moderately affected. And only 20% of the total said that this only slightly affected their quality of life. And when asked how long it took to receive a diagnosis from the beginning of symptoms to the diagnosis, you can see that 10% had more than 5 years of symptoms before a diagnosis was rendered. 20% had 3 years to 5 years of symptoms, and 40% had more than 1 year to 3 years of symptoms. And as you can see, only 30% had a diagnosis between 0 to 12 months of experiencing symptoms. So this is really a large delay in the diagnosis. And when we asked, just for some free text comments about the experience of living with EGPA that were asked in the prior questions, patients said that they had nerve pain in the bottom of their feet, itching and rash, sinus issues, and they felt tired all the time. They endorsed wishing they could regain feeling in their feet caused by the EGPA neuropathy. One person said, I've never been admitted inpatient during my fight with this disease, and because of that, I feel like I'm taken less seriously. There's little acknowledgement of how serious this disease is and how devastating the impact on my quality of life is. There are also some providers who completely dismiss my diagnosis because it's too rare, it can't be that. That is extremely frustrating. Managing ongoing outpatient care is exhausting on top of being sick, and the lack of communication between providers is also difficult. One person said there's not enough doctors that are aware or educated in the disease, making it extremely difficult to find care. Insurance companies make it difficult for sick patients to get the medicines they need, especially biologic medicines and steroid inhalers. So I'll pause to allow a little bit of discussion amongst our group about the degree of patient burden that's experienced by patients with EGPA.
Maybe Panise, I'll start. Those comments on the previous slide, they definitely ring very true, and I think highlight the need to act as quickly as possible to treat this condition, because you see patients talking about their disease activity, but then you also see patients talking about the damage from ongoing vasculitis, particularly the two patients on the first two bullet points who described neuropathy that occurred, that in a large part is irreversible once it occurs. So that's what really struck me about those narrative comments in particular.
Yeah, I agree. It's definitely very sad. And Dr. CEO, go ahead.
Oh, I would just echo that I've heard the same comments from my patients as well. All of these comments sound very familiar to me. And I think that the comment that one of the patients made, that they don't look visibly ill, and because of that, people don't understand how much they're struggling, is certainly a comment I've heard from multiple people.
Yeah, I agree with that. I mean, there are patients who look completely normal and they tell you that they spend the entire day on the couch because they can't just go about their day. And I think I think it's more common than maybe even physicians ask their patients. And so that's part of the reason why, their vasculitis might be under control, and some of their more serious symptoms can be under control, but they're still suffering from other symptoms. And I think that is something that we should definitely keep in mind, especially when we think about adverse side effects of medications. What do you all think about the fact that, you know, doctors are saying it's too rare, so you can't make a diagnosis?
Yeah, I share that patient's frustration, right? It's tough because a primary care physician, a physician in practice, they can't necessarily be on the lookout for everything. But I think hopefully with this program, we'll raise some awareness to be on the lookout for at least particular flavors of disease when an eosinophil count is elevated. To maybe think about a condition like this, because missing it can have some consequences, not just for daily symptoms, but for longitudinal outcomes as well.
Yeah, I always make the joke that, we teach medical students really early to pay attention to a low neutrophil count, but I don't know that the same emphasis is placed on paying attention to a high eosinophil count. And so I think that is also something that we should teach at the earliest stages so that people are recognizing diseases. I mean, it may not be EGPA, it could be another reason for an elevated eosinophil count, and certainly that is something that people should lock into.
Yeah, the information is usually right there in front of you because the eosinophil count's there in the CBC, and people have many, many CBCs with differentials. And I don't know about the both of you, but many, many times I've looked back at charts and looked at historic values and seen that the clues were there many, many years previously.
Absolutely. But you can't diagnose something that never occurs to you.
Agreed.
With ANCA-associated vasculitis in general, not just EGPA, statistically, patients will go about 18 months between the time of symptom onset and the time they actually come up with a diagnosis. That number is even longer for patients with EGPA in particular, which I think makes EGPA particularly challenging for patients who have that diagnosis.
So my brief is to talk to you all about the underlying mechanisms of EGPA and the rationale for targeted treatment, which will flow into the last part of the discussion from Dr. Seo, where he'll talk about the treatment options themselves. So it's embedded right there in the name, eosinophilic granulomatosis with polyangiitis. So it may seem obvious, but it's worth highlighting that eosinophils play a major role in the pathophysiology of EGPA. These cells themselves are pathogenic in this disease. So eosinophils cause damage just by infiltration in organs, but they have their own specific factors that can also mediate organ damage, including the release of cationic granule proteins that cause tissue damage locally. Eosinophils also can cause organ damage through promoting fibrosis, not just through those cationic granule proteins, but through other pro-fibrotic factors, cytokines like TGF beta that they contain. And from kind of a complex mechanism of disease perspective, there's a lot of ingredients that go into the soup of EGPA mechanism. So from everything that we know, EGPA is likely a result of complex interactions between genetic factors, environmental factors, interacting in turn with immunologic factors, as you can see here on the figure. And then looking at the upper left at 10 o'clock, you can see some of the acquired determinants that have been potentially identified as driving EGPA. Things like allergens, infections, potentially vaccinations, potentially drug exposure, other environmental exposures like silica exposure or other occupational exposures. Again, there's not one smoking gun for an acquired determinant of EGPA, but there's a lot of where there's smoke, there's fire, a lot of associations between exposures and the development of EGPA. And then in the upper right at 2 o'clock, some of the potential genetic determinants for EGPA. Again, this is probably a complex disease where there's not one genetic polymorphism that drives disease, but a lot of incremental risk that's additive amongst genetic determinants. Things that have been found are major histocompatibility type class 2 proteins like the HLA-DRs that you see here on the bullet points that have polymorphisms associated with EGPA, and also SNPs for IL-10 also have been seen as associated with EGPA. And then those acquired determinant and genetic determinants translate or interact with immunology that are seen here on the bottom of the screen, the eosinophils themselves that we've talked about, and then abnormal T cell subsets as well, or abnormally regulated T cell subsets like Th17 cells and abnormal upregulation of Th2 cells and pathways, and then potential abnormal downregulation of T regulatory mechanisms as well. And then this is not just an eosinophil and T cell disease. There's humoral immunity via B cells that are involved as well through development of the anti-neutrophil cytoplasmic autoantibodies, the ANCAs, and development of IgG4 as well. This is going to be a theme over the next couple of slides. We'll look at some of these determinants through a couple of different lenses, a couple of different pictorial lenses. So here's one other way to look at this. You can see at the top of the slide some of these same things that we just talked about: genetic predispositions, environmental factors, immune dysregulation feeding into EGPA. And then specifically, again, this is another lens with which one might look at the multifaceted immune dysregulation. On the left, eosinophilic inflammation being abnormal, with IL-5 driving eosinophil development. We'll see that in a slide or two, with the release of the cationic proteins, MBP, ECP, and a couple of other cationic proteins that are housed in eosinophil granules that are spewing out in the picture here and then causing downstream effects on organs like the GI tract, the heart, the lungs. And then that's opposed, or not opposed, but in conjunction with the right side of the screen, ANCA-mediated inflammation, which is humorally mediated inflammation via antigen presentation from the dendritic cell. So you start at the dendritic cell on the picture there at 3 o'clock and then go counterclockwise, interacting with the CD4 T cell, activating B cells, which produce autoantibodies, the ANCAs, which act directly on neutrophils. They may do more than just that, but this is what we know to this point about the immunology. And those ANCAs can do things to the neutrophils like cause them to release neutrophil extracellular traps, so-called nets, which then in turn can lead to downstream organ damage. In this specific case, in this picture, leading to glomerulonephritis that's seen in ANCA-associated vasculitis. So here's a eosinophil-centric view of the world of eosinophil-mediated and organ damage in EGPA, looking at the various eosinophil cationic proteins, MBP, EPO, which we've seen in the previous picture, and also ECP and EDN. And all of these, they do similar things, overlapping things, as you can see from the crisscrossing of the arrows, but there's some specificity between what's been found for these individual cationic proteins and some of the downstream effects. But some of those include the effect on airways, so the asthma portion of EGPA, the airway remodeling portion of EGPA, potential vascular manifestations that are mediated by these granule proteins, including endothelial dysfunction and sometimes thrombosis as well. Some neurologic effects. There can be direct neurologic toxicity, peripheral neurologic toxicity, and cardiac toxicity from eosinophil cationic proteins. And then it's a little bit circular, but type 2 cell activation or Th2 cell activation can be mediated by EDN as well in some data that's out there. And then, cumulatively, that eosinophil accumulation and activation causes tissue fibrosis, thrombosis, allergic inflammation, all the calling cards that are contained in the clinical manifestations of EGPA. So I alluded to this a couple slides ago. IL-5 is extremely important for eosinophil activity, eosinophil development. As the box here says, IL-5 is the most important cytokine for eosinophil differentiation, growth, activation, survival, recruitment to tissues. So it's really at the center of the eosinophil universe in all phases of the eosinophil life cycle. So in the upper right, you'll see that the source of IL-5 is canonically Th2 lymphocytes, but over the last decade in particular, we've learned that a relatively rare in number cell, the ILC2 cell, actually packs a gigantic punch and contains very, very large amounts of IL-5. So both of these cells are the main sources of IL-5. And then that IL-5, as I mentioned, has profound effects on eosinophils from cradle to grave, basically. That IL-5 is very important in the differentiation of eosinophils. If you go from the pluripotent stem cell on the far left, that differentiation into eosinophils via IL-5 is really necessary for those eosinophils to exist, particularly at the far right end of that arrow, almost at the arrowhead at the very end, when eosinophil precursor cells develop into eosinophils. And then IL-5 is necessary for priming eosinophil migration. There are other eosinophil chemotactic factors that we won't talk about today that are important for eosinophil migration, but that IL-5 is extremely important for priming that migration, and eosinophils can chemotax directly to IL-5 as well. And then that IL-5, again, is important for extravasation into tissues, for survival, for prevention of apoptosis while in tissues as well. And then finally, IL-5 mediates activation of eosinophils as well. So while IL-5 itself doesn't cause this burst of granules like you see in the picture here, it's necessary for a lot with other stimuli to cause these degranulation events in eosinophils that are so pathogenic in disease. And then we'll take a moment here now to look at a brief 3D animation illustrating the pathophysiology of EGPA.
Eosinophils are a type of white blood cell with multifunctional roles in humans, including protection from parasitic infections, modulating both innate and adaptive immune responses, releasing immunoregulatory cytokines and signaling molecules, and maintaining tissue homeostasis. Activated eosinophils can cause pathology by a few different mechanisms. Because eosinophils contain cytotoxic granules, chemokines and cytokines, they can directly cause cytotoxic effects through degranulation. They also have the ability to recruit and activate other inflammatory cells through the release of pro-inflammatory mediators. In activated states, eosinophils can play a role in tissue damage, contributing to fibrogenesis, formation of thrombi, vasculitis, and inflammation. Eosinophils mature in the bone marrow and migrate to tissues under the direction of chemokines. Eosinophils can be activated by many cytokines, but one of the most important cytokines for their activation, development, and survival is IL-5. IL-33 aids in this function as well. Eosinophilic granulomatosis with polyangiitis, or EGPA, is a rare disease defined by eosinophil-rich and necrotizing granulomatous inflammation and necrotizing vasculitis predominantly affecting small to medium vessels. It is categorized as a primary anti-neutrophil cytoplasmic antibody, or ANCA-associated vasculitides, but also shares features of hypereosinophilic syndrome. Therefore, both vessel inflammation and eosinophilic infiltration are suggested to cause organ damage. Further, the role of ANCA is not clear, and only up to 40% of patients are ANCA positive. EGPA often involves the respiratory tract, and patients frequently have asthma, sinusitis, and pulmonary infiltrates. However, clinical presentation can vary greatly. Patients may present with single or multiple organ involvement that may also include neurologic, cardiovascular, gastrointestinal, renal, and dermatologic systems. Biologic agents that target IL-5, such as mepolizumab, bind to the IL-5 receptor complex expressed on the eosinophil surface. The agent then blocks IL-5 binding to the alpha chain of the IL-5 receptor complex. This inhibits IL-5 signaling, reducing the production and survival of eosinophils.
Great. And now that you've seen that animation, hopefully you'll understand why targeting IL-5 via biologic agents can be such an effective strategy for depleting eosinophils in disease. And the two flavors of targeting the IL-5 pathway are through targeting IL-5 itself through monoclonal antibodies or targeting the IL-5 receptor through monoclonal antibodies. Starting on the left at targeting IL-5 itself, we have two agents that do that, that are used in various conditions: mepolizumab and reslizumab. As you can see in the footnote, mepolizumab is approved by the FDA for the treatment of EGPA, and mepolizumab, when it's blocked, all of those things I showed a couple of slides ago don't occur. The development of eosinophils from myeloid precursors and their survival and activation in the tissues. And then similarly on the right, when you block the IL-5 alpha receptor with the one antibody that's available called benralizumab, you not just block that signaling of IL-5 to its receptor by blocking the receptor with a monoclonal antibody, you also mediate direct killing of eosinophils from natural killer cells. That's the so-called antibody-dependent cell-mediated cytotoxicity, ADCC, if you want to dust off your immunology from medical school, and that you can see the skull and crossbones there in the picture telling you that this mechanism kills eosinophils directly. And then with that, I will hand it over to my colleague, Dr. Seo, who's going to tell us about treatment for EGPA.
Great, thank you. So when it comes to the treatment of EGPA, it's important to keep in mind that you're actually trying to achieve three goals simultaneously. You're trying to address the disease activity, you're trying to prevent relapse, and you're trying to reduce the toxicity associated with the medications that we use to achieve those aims. So what I'd like to do is provide you with a broad overview of the management of patients with EGPA. And then in subsequent slides, we'll talk a little bit more about the data that's used to support these recommendations and some of the nuances that come up with treatment. So in 2021, the American College of Rheumatology and Vasculitis Foundation published guidelines for the treatment of patients with EGPA. And their overall approach starts with dividing patients into either having severe or non-severe disease. Severe disease means patients who have disease that threatens life or the function of a vital organ. So when you're thinking about vasculitis in general, typically you're going to think about patients who have pulmonary hemorrhage or glomerulonephritis, in particular rapidly progressive glomerulonephritis. For patients with EGPA in particular, you also want to think about patients who have monorized multiplex or cardiac toxicity. So when it comes to the treatment of patients with severe forms of EGPA, remember there are two components that you need to consider. The first component is glucocorticoids, and the second component is a steroid-sparing agent. With regards to glucocorticoids, treatment typically starts with a milligram per kilogram of prednisone daily for about 2 to 4 weeks. Now, for patients with truly life-threatening or fulminant disease, we often start treatment with a pulse of glucocorticoids, such as methylprednisolone 1 gram daily for 3 days. At the same time you start treatment with glucocorticoids, you also want to start treatment with a steroid-sparing agent, which will ultimately allow you to taper that patient off of glucocorticoids. So for patients with severe EGPA, generally we're considering treatment with either cyclophosphamide or rituximab. Cyclophosphamide is the agent that we have the most experience with, and again, for patients with truly life-threatening manifestations or manifestations that seem atypical, we'll still often reach for cyclophosphamide. Rituximab is also recommended for the treatment of EGPA, and that may not make sense at first because you know that rituximab is an anti-B cell therapy, and it may not be logical to think of anti-B cell therapies in the treatment of EGPA. However, there's extensive clinical experience demonstrating that rituximab does seem to work for many patients with EGPA, even patients who had previously not responded to cyclophosphamide, and certainly deserves to be considered. Now, with patients who are initially treated with cyclophosphamide, because of the substantial toxicities associated with this drug, you don't want to use cyclophosphamide for longer than 3 to 6 months. So after 3 to 6 months of therapy with cyclophosphamide, you'll generally transition them to a more gentle steroid-sparing agent. And for us, typically that's going to be either methotrexate, azathioprine, or mycophenolate mofetil. Now, if a patient is treated with this regimen and then relapses and has another severe flare, then we typically recommend treatment with rituximab over cyclophosphamide, again because of the toxicities associated with multiple rounds of cyclophosphamide exposure. So that addresses the treatment of severe forms of EGPA. Now let's talk about the treatment of patients with non-severe forms of EGPA. Now, the majority of these patients are going to have involvement of the sinopulmonary system. So think about patients with nasal polyposis, refractory sinusitis, or bronchospasm. And because of that, there's a strong preference to initiate therapy with mepolizumab, which really effectively addresses those concerns. If, on the other hand, you have a patient who seems to have vasculitic manifestations, let's say a patient who presents with palpable purpura, you may want to think about one of the other agents that we've already discussed, namely methotrexate, azathioprine, mycophenolate mofetil, or rituximab. Now, it deserves to be said that many patients with non-severe forms of EGPA could be treated with glucocorticoids alone, but with most of these patients, as you taper the glucocorticoids, they'll relapse. And because of that, glucocorticoid monotherapy is not typically recommended for most patients with EGPA. Now, if that patient with EGPA is initially treated with one of these regimens, but then has a non-severe relapse, we again have a strong preference for treating with mepolizumab because most of those relapses will have to do with either eosinophilia or something along the sinopulmonary tract. For patients who have already failed a biologic therapy such as mepolizumab or rituximab, unfortunately, there's no evidence-based recommendation for what to do next. But in the next several slides, we'll talk about some options. You'll notice that all these treatment recommendations start with glucocorticoids. And the good news is that glucocorticoids are incredibly effective for the treatment of EGPA. And if that's all we had to say about glucocorticoids, we might not have the need to talk about the treatment of EGPA at all. We would just treat with steroids. Of course, we know that the downside of corticosteroids is they come at a significant cost. And some of the morbidity associated with treatment with glucocorticoids is listed on the slide. This, unfortunately, is just the tip of the iceberg, and problems with glucocorticoids arise not only with the amount of glucocorticoids that you use, but the duration of therapy. And it's become more obvious over time that patients who are treated with low doses of glucocorticoids, if used for long periods of time, can suffer significant effects, including myocardial infarction, stroke, cataracts, glaucoma, osteoporosis, and other effects. And it's the reason why managing these patients with drugs other than glucocorticoids is so important. As the expression goes, it takes a village. So EGPA, because by its nature is a multi-system disease, it generally will take more than one clinician to manage these patients. and these patients will often pick up a team of physicians who will help manage individual organ manifestations as they occur. So at the heart of this team is often going to be a pulmonologist, an allergist, and a rheumatologist, but certainly patients who have cardiac involvement should have a cardiologist on board. Patients who have gastrointestinal manifestations will likely need a gastroenterologist. And dermatologists can also be very important in managing refractory skin disease associated with this diagnosis. Regarding follow-up with these patients, one of my colleagues likes saying that it should be illegal to get a CBC without an eosinophil count, and I think for patients with EGPA, that's certainly true. In rheumatology, we're very used to getting acute phase reactant measures, such as a C-reactive protein and an ESR on a regular basis as well. These are non-specific measures of inflammation, and while an increase in these numbers don't necessarily mean that a patient is having an exacerbation of the EGPA, it's probably a good hint that you should take a closer look at that patient. You also want to think about monitoring kidney function, particularly by a urinalysis, especially in patients who have had a history of glomerulonephritis. Glomerulonephritis is not too common among patients with EGPA, but you definitely want to think about monitoring the kidneys in patients who are ANCA positive, since those patients are more likely to develop glomerulonephritis than patients who are ANCA negative. You also want to think about imaging, particularly baseline imaging, in case the patient develops further complications down the road. At minimum, you want to get imaging of the lungs and of the sinuses, since sinus disease is so common among these patients. You also want to get pulmonary function testing, since pulmonary function is such an important disease manifestation in patients with EGPA. And finally, you want to remind your patients to keep you informed of other issues that arise. And rather than give the patient a litany of the complications that can arise with a diagnosis of EGPA, I often just tell the patients to let me know if their physicians seem to be confused by something that's occurred, just so that I can make sure that it might not be a manifestation of EGPA. I talked initially about some of the subtleties of management, and this happens to be one of them. So when rheumatologists use methotrexate and azathioprine, we generally use them interchangeably. And for most autoimmune diseases, both of the drugs are equally effective. However, there are two studies that indicate that azathioprine may not be the ideal drug for the treatment of patients with EGPA. The first study I want to talk about is CHOOSE-SPAN-2. CHOOSE-SPAN-2 is a randomized controlled trial from the French Vasculitis Study Group that tried to look at the effect of azathioprine for the treatment of patients with non-severe forms of vasculitis, including EGPA. Now, for the purpose of this discussion, we're just going to talk about the EGPA data. But they took these patients and they randomized them to treatment with either azathioprine or placebo, in addition to a protocolized glucocorticoid taper. The patients who were treated with azathioprine received azathioprine at 2 milligrams per kilogram per day for 1 year. Although patients were only treated for 1 year, the primary endpoint was actually at 2 years, and the question they tried to answer is whether or not azathioprine treatment decreased the rate of relapse among patients with EGPA. And the answer seems to be no. And in fact, when they looked at the requirements for glucocorticoids and the effect of azathioprine on asthma, they were not able to demonstrate that azathioprine had a benefit for patients with EGPA. This is actually supported by a second study, which is much smaller and retrospective, that looked at the effect of azathioprine either for remission induction or remission maintenance among patients with EGPA, and compared those effects to patients who had been treated with methotrexate. If you look at the graph in the top left of your screen, you can see the effects of methotrexate and azathioprine when used for remission induction for patients with EGPA. And you can see that the patients who are treated with methotrexate seem to have a faster response. And that was associated with glucocorticoid sparing effect. Just below that, you can see a graph that indicates that when these drugs are used for remission maintenance in patients who had previously been treated with either rituximab or cyclophosphamide, patients who had started on treatment with methotrexate seem to remain on methotrexate for longer periods of time than patients who were treated with azathioprine. Now, in general, you would assume this might be due to a drug side effect, that there was some reason why the azathioprine was stopped. But in fact, when you look at the data, the patients who are treated with methotrexate not only stayed on the drug longer, but they are also more likely to develop drug side effects. So it seems like these patients were staying on methotrexate despite those side effects, which implies that there's a benefit to this drug when used for remission maintenance, especially when compared to azathioprine. That seems to be supported by the final graph on the screen that seems to demonstrate that patients who are treated with methotrexate overall have a lower requirement for glucocorticoids than patients treated with azathioprine. Now, I need to emphasize this is a retrospective study with relatively small numbers, and because of the number of ways they did this analysis, the differences between these groups in absolute terms is quite minimal. However, it's certainly interesting to think that maybe these two studies taken together indicate that azathioprine maybe shouldn't be our first choice when treating patients with EGPA. That seems to be reflected by the patient survey that we had conducted, where it seems that about twice as many patients are maintained on methotrexate compared to azathioprine. Now, if you look at the drugs that these patients reported using, there are going to be no surprises. That many of these patients are still on oral glucocorticoids, and they're also on agents including interleukin 5 inhibitors that they're using to treat the sinopulmonary manifestations of this diagnosis. Now let's talk a little bit about the data that supports the use of interleukin inhibitors for the treatment of EGPA. And to start, we're going to talk about the MIRA trial. The MIRA trial was a randomized controlled trial that looked at patients with relapsing or refractory EGPA who required at least 7.5 milligrams of prednisone to stay in remission. And these patients were randomized to receive treatment with either mepolizumab or placebo. Mepolizumab was dosed at 300 milligrams once a month. This study had two primary endpoints. The first was the amount of time that the patient stayed in remission, and the second was whether the patient remained in remission at week 36 and week 48. And not to give you too much of a spoiler, but this trial was positive and met both primary endpoints. And if you look at the graph on the left, you'll see what I think reflects most patients' experience with this drug. So when you first start the drug, you'll notice that there's a ramp-up period, that most patients need to be on this drug for several months before they achieve a maximal effect. But when that maximal effect is achieved, patients don't seem to develop tachyphylaxis. In other words, the patient continues to respond in a predictable way to this drug. Now, unfortunately, this graph also demonstrates that there doesn't seem to be much of a honeymoon period associated with treatment with mepolizumab. So after the patient stops using mepolizumab, a few months later, they're pretty much back to their baseline state. The graph on the right demonstrates the rates of relapse in patients who are treated with either mepolizumab versus placebo. And again, you can see there's a substantial benefit to the treatment with mepolizumab, particularly at the 3 time points that they've looked at in this study. Patients who are treated with mepolizumab are about twice as likely to have at least a 50% reduction in their baseline glucocorticoid dose when compared to treatment with patients who are treated with placebo. Numerically, you can see what this means. So at the end of 52 weeks of treatment, most patients treated with mepolizumab on average were on 5 milligrams of prednisone a day, versus patients who were treated with placebo, who ended up being on approximately 10 milligrams of prednisone a day. Now, this might sound like a small difference, but then you have to think about the 20 or 30-year-old patient that you just diagnosed with EGPA, who may be on prednisone for decades, and you can see how important these interventions are for our patients. I'm pleased to mention that mepolizumab was not the only interleukin 5 inhibitor that is effective for the treatment of patients with EGPA. And we know this because of the Mandara study that looked at a very similar patient population, so patients with relapsing or refractory EGPA, who were randomized to treatment with either benralizumab or mepolizumab. Mepolizumab was dosed at 300 milligrams once a month, which was the dose that was examined in the MIRA study. Benralizumab was used at 30 milligrams once a month, which is a little bit higher than we're currently using for eosinophilic asthma, since most patients with eosinophilic asthma will eventually be treated with only 30 milligrams once every other month. The primary endpoint of the study was again patients who achieved remission at week 36 and week 48, and there didn't seem to be a difference between these two groups. Now that I said that, it's important to note that this was a non-inferiority study with a margin of error of 25%. So that was a quite generous margin, and unfortunately, the study was not able to demonstrate if one drug was better than the other. But certainly, it's encouraging that benralizumab will probably have a role in the treatment of EGPA in the near future. Benralizumab is not the only drug that we'll likely be able to use for the treatment of EGPA. There are other agents directed against interleukin 5 that are currently under study. There's also tezepelumab, which is a TSLP inhibitor that is already approved for the treatment of refractory asthma and is now being examined as a potential therapy for patients who have EGPA. JAK inhibitors also are widely being used for a range of autoimmune diseases, and not surprisingly, they're also looking at it as a potential therapy for EGPA, and hopefully there'll be some news about this soon. The reason why this is so important is because patients still are lacking in terms of quality of life. So if you look at our patient survey results, you'll see that 40% of patients say they're extremely satisfied with their quality of life, whereas only 60% are slightly satisfied. In terms of response to biologic, you can see that about half of patients are either moderately or extremely satisfied with their response to biologics in terms of their quality of life. But that still means that for about half of patients, we could be doing better. And now I'll open this discussion up to my colleagues. So how do you decide which patients to be treated with a biologic?
Yeah, it's a great question. I think back at the first slide you showed, Phil, with the treatment algorithm from the ACR, um, and anti-IL-5 biologics being reserved for patients for maintenance disease. And I think that's reasonable. I do think we'll probably find that there's a role as an adjunct therapy and induction. There seems to be little downside, but I also think for most patients with the confirmed diagnosis of EGPA who are in that maintenance non-life threatening phase of their illness, I think most of these patients should be getting a biologic, unless there's a compelling reason not to, or if they're controlled with very minimal alternative immunosuppressive.
I absolutely agree. And in fact, I'm old enough that I remember having a patient population of patients who are stuck on 10 to 12 milligrams of prednisone a day. And I just had nothing else to offer them, regardless of what I tried treating them with. As soon as I tapered closer to single digits, they would have asthma exacerbations or worsening sinus disease, and I would immediately have to increase their prednisone. And drugs like mepolizumab and benralizumab have definitely changed that.
Yeah, I mean, I agree with all of that. And I think, the question probably is more what to do with people who, they're not active, severe, and they've had the relapses in the past, and now they're maintained on prednisone. And what dose, is enough to put somebody on a biologic. And I think this is really individualized, but I certainly do approach this question with my patients just to make sure that, they're not on, they don't need something more than just 7 milligrams of prednisone, for example. And I think, we'll have to wait and see what happens with benralizumab, but I would guess that it'll become available for patients with EGPA. And I think the next question then will be, which one do you pick? And so, and I don't think we have answers there in terms of which biologic to choose, but I don't think this is unique to EGPA. These are questions that are coming up in all the diseases that we're treating with various biologics.
Right. It is interesting that in the Mandara study, they seem to demonstrate that patients who are treated with benralizumab were more likely to get tapered completely off of glucocorticoids versus patients who are treated with mepolizumab. But unfortunately, it didn't seem to correlate with any of the secondary outcomes of interest. So it's not clear that one drug is really better than the other from that study.
Yeah. I mean, I think you have to remember that when we first did the MIRA study, we didn't have, I mean, it was placebo controlled. So when you're giving patients, one drug or another, and you're more comfortable with the understanding that patients do respond to eosinophil targeted therapies, that tapering may differ, amongst investigators. So, I don't think we have all those answers, but just thinking about why patients might get off steroids, it's an interesting question.
Sure. As an aside, I think it's incredible that we have two randomized controlled trials for such a rare diagnosis, and that's really terrific that we're able to talk about stuff like this.
Yeah, Phil, you're talking about the olden days. You're not that old, but yeah, but it is amazing in a very relatively short period of time that we have, a new tools and potential new tools for changing the lives of these patients. It is fantastic. I think we've all had experience with people who've just been stuck, and to that point about being stuck on even a relatively low dose of oral corticosteroids. To Paniza's prior point, if you kind of think about the asthma world, it's never really acceptable to have somebody on chronic oral corticosteroids, and those are all patients in the asthma world that you would consider a biologic in. So, maybe that is what we should be thinking about in EGPA. That any exogenous chronic oral corticosteroid is not great, but we're starting from a different kind of mental set point about the amount of immunosuppression that is necessary to control disease otherwise. So it is an interesting kind of psychologic exercise of where you're starting from with the set point of what's reasonable or not.
100%. I mean, I think it's interesting. What we decided was, remission in terms of prednisone dose for Mira was 4 milligrams, right? Less than 4 milligrams was considered remission. But really, is that the right target? Should zero be the target? And I think absolutely. If you look at the asthma world, you have a patient who has 2 exacerbations in a year. That's not good. And I think historically we've tolerated much higher doses for patients with EGPA, but that might be why they do have so much of a burden on their quality of life and have so many side effects that they complain about in the surveys that we saw.
There's all sorts of statistics that indicate that the longer you put someone on low dose glucocorticoids, the more likely they are to suffer these bad side effects, even though we traditionally talk about these low doses being physiologic, which turns out it's a lie. It's any dose of prednisone is going to have some toxicity as long if you use it long enough.
Absolutely. Yeah, and I'm hopeful about some of these other mechanisms as well that I think what I presented my portion of this hour in thinking about mechanism, hopefully made the point that there's some eosinophil mediated mechanisms that we are targeting with these biologics, but there's some non-eosinophil mediated mechanisms as well that hopefully will start to unlock a little bit more and understand what role they may be playing. I think when we give rituximab to patients for maintenance therapy, we're targeting perhaps the humoral component, the abnormally regulated humoral component, but unlocking potential epithelial contributions with targeting TSLP and other alarmin cytokines may be beneficial. I think that other ways of targeting eosinophils that maybe oral agents, et cetera, that are in development may also be of interest as well. But I think there's still a long way to go, even though we have what we've done in the last decade has been amazing. I think there's a long way to go to maybe even start thinking about, how might we think about curing some of these patients.
Yeah, definitely. And also one thing that is not, I mean, is much more advanced in the asthma world is the idea of endotypes and molecular differences between patients. And I don't think that we are there yet for EGPA. I mean, I think there's a general recognition that ANCA positive is different than ANCA negative, but even amongst the ANCA negative, maybe there are some patients that would respond better to one biologic or another. And I think as these studies are performed, maybe something will fall out in terms of picking, which therapy is best for which patient.
Yeah.
Or combinations of biologics. We don't really talk about that at all, but there might be a point at which we're able to use target multiple pathways in an individual patient because that might be what they need.
Yeah, and I have to admit, I have to raise my hand that in clinical practice, I have done this here and there, and adding other type 2 biologics to eosinophil depleting therapy. It's obviously not evidence based, but anecdotally, I've gotten some mileage out of that.
Likewise.
Great. Well, should we wrap it up?
I I think so.
Great. In that case, I'll take the summary. EGPA may be under-recognized due to its rarity. High eosinophil counts on lab workup should be noted. Next, EGPA requires a multidisciplinary approach. It takes a village for diagnosis and treatment. Corticosteroids are first-line therapy, but are associated with significant side effects and toxicity. Progress in the understanding of EGPA has provided us alternative treatment options with different mechanisms of action. And finally, consider biologics and cytotoxic therapies in patients with steroid-refractory disease, in cases where you're stepping down therapy, and in patients who are relapsing. So as more therapies emerge and advances in EGPA continue, clinicians will have more tools to better diagnose, treat, and care for patients. So with that, I'd like to thank you personally for joining us this evening. And I'm sure Dr. Seo and Dr. Corey would like to thank everybody as well.
Yeah, thank you for joining us. I think this was also very fun to talk with you, both Phil and Praveen.
Thanks, everyone.
Great. Thanks. Good night, everyone.
Thank you for listening. Remember to download the slides and practice aids and complete the post test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Campaign Urging Research for Eosinophilic Disease. This educational activity is supported by an independent medical education grant from GSK. To access all materials for this activity, visit peerview.com/TTA860.